on preventing and managing COVID-19 in the workplace. This is Karen O'Hara, the Director of Marketing and Communications at WorkCare, your moderator for today's session. This is our 51st consecutive week. So next week on number 52, you can expect some celebration that we've made it through the year, and we'll have a special session for you and tell you what we plan to do in subsequent weeks. If you're a regular attendee, we're happy to have you back. You know our routine. If you're just joining us, you'll see that we follow a familiar format, and we will be covering the same issues we always do, plus some special information on today's topic. Please submit your questions using the Q&A function in Zoom. We'll answer as many as we can during the duration of the session, and we'll post all questions and answers on our website at workcare.com. We also post the recording of each session on our YouTube channel, so you can find those are a great resource for you if you want to look back at materials that we've covered over the past year. I'd like to introduce our presenter, Anthony Harris, MD, MBA, MPH. Dr. Harris is board certified in occupational medicine. He's our Chief Innovation Officer and Associate Medical Director. He's also our lead clinician for WorkCare's COVID-19 response. So I'll turn it over to him. Thanks again for joining us.
Excellent. Thank you, Karen. And thanks, everyone, once again for joining us. Today, we have a fun topic in regards to things that have been around for a little bit that we may or may not know about, but have we gone deep in terms of anticipating what the effects of what we're going to talk about today, today's topic, will actually have on the workforce, potentially for some time to come. We're talking weeks to months down the road, even after we're hopefully on the other side of this COVID pandemic later this year. So without further ado, we'll jump into the topic for today. The format, we got a little festive with the colors here today, just for some levity, but we want to talk about, in the same format, our clinical update, followed by some pathology, microbiology. We'll jump into the numbers in terms of epidemiology, how we're doing locally in the US and abroad. And we'll talk about prevention and finally some workforce strategies as a result of what we've learned today in regards to the topic at hand. And so what is the topic at hand for the clinical update? Today, we're going to talk about something that's already on this list, right? In a way, it's on this list and has been for some time. The headache is part of it, but further down the list, third from the bottom, confusion and delirium, okay? We have now colloquially called this COVID brain or COVID brain fog, right? You've probably heard about that, but do you really know what it is? And do you understand fully the impact it may have to the workforce, so that, again, we're putting in place measures to help prevent any untoward outcomes in regards to the impacts from COVID brain fog. So COVID brain fog is something that is described now more completely in the literature in regards to it's real, right? At first, we early on in the pandemic had symptoms associated with this confusion and delirium, more associated with those who were being hospitalized, right? And those who had pre-existing conditions or were in the 65 and older age group. And we associated their COVID neurologic symptoms with the severity of their impact of COVID infection, right? And we associated, again, the long-term effects from a neurologic standpoint, with that severity of hospitalization as a result of COVID, their COVID infection. And so what we know now today is that brain fog is something that's described not just in those who have severe or moderate cases of COVID, but even in mild cases, all right? And so when we're talking about symptoms from COVID, fever, cough, shortness of breath, all familiar, right? But this lingering mental fog is something that is now, again, documented pretty well, and people complain about memory loss, trouble finding words, problems with attention, attentiveness, feeling overwhelmed, like anxiety being a strong component to this COVID brain fog, all right? And these are, again, not patients are not employees that have had stroke or any kind of severe neurologic onset as a result of their COVID infection. We're talking, again, mild infection of COVID, recovery, and lingering brain fog. And as we get further into the descriptive of how common is it, we'll talk about those numbers here in a second. But again, people forgetting names of others, right? Forgetting where they are in conversation, casual conversation, or in the business environment, losing track. And anecdotally, I've encountered this with some of the nurses that we know have had a COVID infection and recovered, and frankly said themselves, as well as their husband, had still very significant brain fog as a result of their infection that they recovered from even a month to 2 months ago, right? And if you look at some of the burgeoning literature, the persistence of brain fog from COVID can last as long as 6 months. In some cases, neurologists are suggesting that the effects may be permanent in regards to neurologic effects. So it's something that we need to be mindful of, and we'll talk more about the impacts potentially and what do we do about it. So as we continue, other symptoms, again, when we're talking about the brain fog, we want to point out, it's not severity that plays a role in whether or not you experience brain fog, okay? And these changes typically aren't profound, right, to the point where it's impairing people's motor ability, right, their movement and things of that nature. But again, it can be troubling from the standpoint of difficulty with just their normal activities of daily living and or their job in particular. And if we look at then the rate of potential impact from COVID brain fog, one study looked at previously drawing inferences from SARS and MERS, right? And this looked at patients who were hospitalized oftentimes from SARS and MERS previously. Again, this is not SARS-CoV-2, this is SARS-CoV-1 and MERS, the Middle Eastern Respiratory Syndrome. And these patients, 40% of the time, had neurologic or psychiatric illness as a result of their infection, all right? And so it's something that is not new in terms of impact from viral infection and after recovery, but something that is novel in regards to the long-term effects from mild disease now. Again, SARS and MERS previously back in 2003, we were talking severe cases having these lingering effects. So now let's talk about then the pathology that drives this phenomena we're seeing in regards to COVID brain here. So, sorry, lost the PowerPoint there. That's a first. We'll get it back up here in 2 seconds. So as we talk about the pathology for COVID-19 brain fog, we want to dig into what clinicians are understanding from biopsies and autopsies of those who have succumbed to COVID or from some other scenario and they had a previous infection of COVID-19. And if we look at then these pathologic slices of the brain, one of the things we're seeing in these histological sectionings is a prevalence of immune cells, right? Inflammatory cells in the brain that typically are not in the brain, okay? And we'll point out these cells in particular and the impacts of these cells, but know that the research now is becoming more robust to help us understand what's causing this brain fog. And if we look at some of the literature that was published in JAMA, even recently as February 12th here, we're seeing the immune cells present in blood cells. In the similar way that the blood cells we found that led to erectile dysfunction we mentioned before, or increased risk of cardiac impact from the gumming up of the blood cells and limiting blood flow to these end organs, so too are we now seeing this phenomenon happen in the brain, okay, in the blood vessels in particular. And we see that these particular cells that can clog up the blood vessels, which are typically only large enough for passing red blood cells, right? Pretty small cells. We find these large cells called megakaryocytes. Megakaryocytes are part of the immune system. And typically, in this case, the megakaryocytes that we're identifying in the brain live in the bone marrow, right? And never before really have researchers found megakaryocytes from the bone marrow in the brain as a result of viral infection. And so this arrow points to one of these megakaryocytes, and it's sitting in the middle of this blood vessel. And as you can see, it's taking up the full volume of that blood vessel. And so this is, true pathology here that we now are understanding as a result of COVID-19 infections, even mild so, right, causing long-term effects from a neurologic cognitive standpoint. And so again, you can imagine the need to understand it to the point where we can simplistically communicate it to our workforce so that they're knowledgeable about communicating their effects from COVID in terms of their neurologic presence, absenteeism, presenteeism we're talking about, right? And providing solutions for them as they continue to recover and feel potentially the impacts from neurologic deficits. So we'll pause there on the pathology. We'll get into our epidemiology as we look at updating everyone here on how we're doing in the US with regard to COVID-19 infections. We know that the number of cases have been declining now for 6 weeks straight. Okay, last 2 weeks ago, last week where we were at 19.3, and we're still around 19.9 as of today, right? In terms of 7-day rolling average across the country, we're seeing lower numbers. When we talk about then deaths, we also are seeing a decline there. Deaths per 100,000 at 0.9, 2 weeks ago, 0.6 last week, and still at 0.6 this week. Okay, so again, everybody is pretty optimistic about what this represents for the impact US-wide and the opportunity to start getting back towards a sense of normalcy with our freedoms, if you would. And we'll talk more about that in a second, and we'll talk specifically about things that states are doing that we may or may not agree with here. So when we look at a trend line that we want to present here on a rolling average, this is CDC data looking at since January 22nd, how we've done over time. And again, that's January of last year, 2020, all right? And we can see how we've performed. We can see the dramatic drop off here. But to note that we are still at levels, right, that are about where we were when pandemic started peaking the first time. Okay, so it's not an opportunity for us to say, okay, we've won, we're on the other side of this. It's an opportunity for us to recognize that there's still potential for transmissions at a significant level as it was before last spring, last summer. As we look globally then to trends across the pond and other nations here, we're seeing, and we have seen again, downward trends in other nations 2 weeks ago, where we were last week, and where we are today. All right, we continue to see on a 7-day rolling average cases go down. When we talk about per million, we're seeing similarly a downward trend. We see France experiencing 2 weeks ago a little bump in their numbers, but overall trending downward here, as well as the US. Again, France, Italy, seeing small little bumps there as we fast forward to today. We'll continue to pay attention to that, and we'll also dig into next week very likely, is this a result of variants, right? Those variants that we know have a higher transmissible rate and can potentially cause poorer outcomes as well. If we look at deaths, again, trending downward here over the last 2 weeks, where we were last week and then where we are this week with a small little bump there. And nothing to be celebratory about yet, but at the same time, again, positive trending downward, not just in the US, but abroad here across the board. If we look at per million, what that looks like, again, nothing surprising here, downward trends typically here across the board in Canada as well. So there's a lot that we can glean from not just this data, but when we couple it with the testing data, we can see that testing is down in the US Testing is down in India, but up in the UK, up in France a little bit, trending upward. So the fact that they are trending down across the pond and having increasing number of tests, again, undergird that we truly are seeing lower incidence of disease and not just misrepresenting the burden of illness in these particular nations. And hopefully that's the case here in the US. As we fast forward to the number of tests conducted on a daily 7-day rolling average, we can jump to per capita and see still a downward trend in our testing in the US, particularly upward trend in the UK, again, positive that they haven't bumped. Italy, their tests have gone up. That may be why they're seeing a little spike in their numbers, because their testing is going up on a daily rolling average. And we'll see how that plays out for us, with the CDC now stating that they really want to start pushing increasing tests as kids are going back to school, right? So we'll see how that pans out over the next couple of weeks. If we look at positivity rates, we are seeing this continue to trend downward, which is in the right direction in the US. Again, Spain had a little bump there 2 weeks ago, still trending down, started trending down last week, and still trending down today as we are in the US. We added South Africa to this data set just so we can see whether or not that South African variant is having an ill effect on the trend in South Africa. In this case, it's trending down in South Africa as well. If we look at then zero in on US and what has happened, we see a small bump that we mentioned here briefly, and we'll talk about that little bump there and really get into what may be the cause of that, and hopefully not a result of, it's unlikely to be a result of variants at this point in time, as we'll talk about the variants here in a second, because of the sheer number of variants not being significant compared to the rest of the cases that we're seeing. But we'll analyze that a little bit more deeply here as we move forward. So jumping into the numbers of vaccines administered, we're doing well in the US. We were 2 weeks ago. We had a little downward trend on a 7-day rolling average in terms of administered doses, right, last week, but we are trending back up this week. So we're doing well in terms of getting the numbers of vaccines out there. Now, are we up to par with where we thought we would be at this point in time? The answer is still no, and we'll look at the numbers here in a little bit more detail. On a per capita basis, per 100 people, we can see where Israel is still in that #1 position, UK and the United States 2 weeks ago, where we were last week, and where we are this week. Again, we're trending upward in the right direction when we're talking about vaccine administration here in the US. If we look at the absolute numbers here, 71 million is where we stood 2 weeks ago with 55 million administered. We increased that to 82 million and 65 million respectively. And now we're over the 100 million mark in terms of distributed vaccine doses, okay? And we're at 78 million. So we're still pegging at that 3/4 mark, right? Historically, when we started doing the distribution and administration of vaccine, we've been hanging out around the 3/4 of the distributed doses being administered for those, if we're all encompassing, right? But then when we look at and isolate those who have received both doses, it's far less, right? And that's the number you see here on the right, the 26 million. So that continues to be only 1/4 of the total number distributed, roughly, right? So 3/4 is where we've been pegged at administered versus delivered, 1/4 for receiving both doses. And we'll see how that trends now that Johnson & Johnson is approved, right? We have the one-time dose. Tony Fauci has now said any vaccine you can get your hands on, he recommends you take it, right? And when we talk about the efficacy of Johnson & Johnson, I don't have this slide up for the efficacy of Johnson & Johnson, but we'll talk about it here because it's obviously germane to the topic at hand. The Johnson & Johnson vaccine is only about 66% effective at preventing moderate and severe illness from COVID-19. Okay, and that's compared to 90 and 95% for the Moderna and the Pfizer vaccine preventing symptomatic infection of COVID-19. So obviously the question is, do we recommend in the clinical community getting the Johnson & Johnson one dose? And the answer is yes. If you have access to that vaccine, it's still going to put you in a better position in regards to untoward outcomes and preventing transmission of COVID-19 in the community if you're able to get the Johnson & Johnson dose. After one dose of the Pfizer or the Moderna vaccine, per the phase 2 and phase 3 clinical studies, recall that about 80% of people have immunity, develop immunity as a result of one dose of the Pfizer and Moderna. So that's still more efficacious than the one dose of the Johnson & Johnson vaccine. But we also know the logistics of the cold chain that has to happen with Pfizer and Moderna. So globally, the one-shot dose of Johnson & Johnson, with its logistical advantage of not having to be kept at low temperatures, is going to be better for global herd immunity from a vaccination standpoint, potentially, because of access to nations that don't have the infrastructure that we have here in the US. And as well, it's slated that the Johnson & Johnson vaccine will help with underserved communities, not disproportionately, but because of access and logistical ease of distribution, that is going to be hopefully a boon to us. Now, the numbers for Johnson & Johnson distribution is slated to be 20 million doses by the end of March. All right, and over 200 million doses is where we are hoped to be, where the administration, the Biden administration hopes to be by June. And so when we talk about the timeline update to the general public having access to the vaccine out beyond the 1C category, we'll update that on next week during our presentation so that we can start to anticipate when the rest of our workforce that are not in the essential workforce will have access to the vaccine, and we can plan accordingly to begin to bring the majority of people back after they've been vaccinated into the workplace. As we talk about then those variants that we've been watching, the UK variant here, B117, the South African variant here, B1351, and then the variant from, in this case, shucks, I just blanked on the name here. I'm having a junior moment during this 51st presentation here. So the P1 variant we've been watching as well. And these variants that we've been watching do not include the California variant, right? The California variant, now that makes up the majority of the cases in California, is something that has not been tracked from a severity standpoint as much. We mentioned it last week. We will talk about it more in the future. But right now, we're not seeing data published by CDC tracking the California variant to the extent of these other three variants here. So when we look at where we were at the spread of these variants 2 weeks ago versus last week and this week, we can see the increasing distribution of this variant amongst the states. And that's something to be concerned about, right? Again, we talked about the UK variant being responsive to both natural immunity after you recover from COVID and acquired immunity from the vaccine. The South African variant having some potential to escape the natural immunity, right, and lower efficacy of the vaccines with both the Pfizer and the Moderna, as well as the Johnson & Johnson vaccine. And then when we talk about the final P1 variant, the impact there not as severe from escaping the immune system as well as poor outcomes. So we'll continue to watch, but again, potential for increase, all three having increased transmissibility. So the potential for another spike as these variants populate the US is there. And that's what we need to be concerned about from the perspective of not easing restrictions too soon, which is what the director of CDC just came out and said, I believe it was just this morning, right? Warns the states and the governors not to ease up too quickly because of the potential that these variants represent and the potential for going backwards with regard to transmissions. And again, we saw a little bump, and we'll talk about that bump again in terms of incidence here in the US. So as we talk about long-term effects again from COVID-19 infection, and we talk about what the ramifications of COVID brain fog is, I know that CDC is listing as a long-term effect the brain fog, okay? And so it's something that we should be, again, communicating to our workforce, and we need to understand some of the additional data around the prevalence, right? And so if we look at this particular study that examined 120 patients that were hospitalized with COVID-19, looking for now effects long-term of brain fog and cognitive impairment, 34%, up to 34% of these individuals had some memory loss long-term, right? And that is 110 days, almost 3 months after they recovered or after they were admitted to the hospital. So again, long-term effects that can linger in a proportion that's significant. And now, do we really know the true incidence or prevalence of brain fog in the US as a result of COVID-19? The answer is no, right? That it's something that is difficult to ascertain because individuals may not recognize, one, that the cognitive difficulties they're having, albeit oftentimes mild, like word finding and recall, was actually associated with their COVID infection, right? And these are young, healthy, the age range that we're seeing the prevalence of COVID brain is in the 30s, early 30s. So they may not even know to mention to their provider, their PCP, or their supervisor at work that their cognitive difficulties are a result of COVID. And so that's why we need to push forward with education. We'll talk more about that as a means to mitigate some potential risks as a result of COVID and COVID brain fog. So now let's start talking about and looking at the rate of cases here in the US as a result of movement of people in the US. We've presented this data before. We're going to revisit it now because it's relevant to the trends that we need to follow for the states and impact to the workforces in various states. All right. And so this data, again, is looking at several things. We're looking at transit stations, how much people, at what rate are people moving in transit stations, and the trend in workplaces, retail, recreation, and then comparing that, overlaying all of that on a 7-day rolling average, 7-day absolute change in incidence of disease. All right. And so as we zero in on each of these metrics here, we can look at the transit data and we can see over time how the transit data has trended downward. And again, downward being that the lower the number, the lower the change, the negative number, right, the less people are out and about. All right. And towards up to the baseline there that you see, that 0 mark, that was the baseline pre-COVID last year. That was tracked, and everything is compared to that baseline of transit activity of people in the US. And so down 26% is where we stand right now. And that trend downward here during these winter months was downward. And that does correlate with the downward trend of cases, right? And we know that the less people are out and about, the less risk for transmission exists. When we talk about workplace, people actually in the workplace, we can see how this has really stayed flat. If we look at an overall trend here, there hasn't been a tremendous move up or down. We see these particular low spikes here. Low spike around Christmas, which is around this January here. I'm gonna grab my laser pointer here. So low spike here at Christmas, and at New Year's, we had a spike here, downward, and we'll talk about that spike in particular when we jump to retail and recreation as well. So as we look at retail and recreation, we can see the downward trend up until recently, where we're starting to trend back up, right? And that's an overall trend that we know exists from economic pressure to reopen. And so we'll see how this potentially impacts transmissions, again, as we see this little small increase here nationwide. So let's pick on a particular state, and you know the state I'm going to talk about probably because it's been in the news. Let's pick on Texas, right? The Texas governor just reopened business in terms of retail, restaurants, lifted the mandatory mask statute, right? And so now people can go back to their favorite spot 100%, right? And potentially with no masks on. So is that likely to result in some transmissions? Let's look at the data and try to ascertain an answer, draw an inference, right? So if we look at the downward trend of cases here in Texas, and we correlate that, we can see the downward trend was preceding these low dips here in the both transit, workplace, and retail, right? We can see where New Year's was, Christmas and New Year's was as well. And we see also that this downward trend of these three metrics was overlaying what happened in Texas with regard to the severe winter storms. So those winter storms impacted potentially the number of transmissions as people stayed indoors and they weren't out and about. Again, this data is directly correlated to people being out and about, mobility changes, and potentially now seeing that downward trend at a nidus and now starting to go back up, right? As we see the trend of retail go back up. So retail, workplace, and transit stations. So now that things have been lifted, it is likely that we're going to see an upward trend of cases, right? Intuitively, we would say, yeah, of course, that sounds reasonable to estimate an upward trend, a small bump. To what extent, however, will play out here in the data, and we'll watch this over time and use Texas as a use case of hopefully other states not doing, if we see an upward trend, not doing what Texas has done. And certainly that is what the CDC director has said so far. Now, if we jump into our next metric here, we want to look at new admissions of patients to the hospital, right? This is obviously a lagging indicator of incidence. However, this downward trend that we continue to see here is positive news that undergirds that we're doing better than we have been, but still at a rate higher than where we were fall of last year and when we spiked earlier in the spring. So we will continue to pay attention to this trend of hospital admissions. We'll jump forward through this one and we'll jump back into the COVID brain impact, right? So we want to talk about what trend, what do we need to look out for? How do we address this in the workplace? Because again, if we're talking about in particular a population of the workforce that has had COVID and potentially up to 30%, right, of those individuals having some type of cognitive impairment, we should be mindful to address that with the workforce and provide some type of education around what to do, right? And have a process in place on helping them cope with that as well in the workplace. And so one of the suggestions is just education and communicating to your employees if you are having some signs and symptoms of brain fog, right? Your word finding, things of that nature, mention it. And it's okay. It's a safe place to mention that you are having these symptoms without fear of job loss, right? Because one of the things we know is that if you in particular have a safety sensitive job, you may be putting others at risk if you aren't operating at your highest level of cognitive ability, right? So cognitive impairment is definitely something we should be educating the workforce on, as well as having a plan in place and an evaluation for those who have safety sensitive jobs. So what could that look like, right? In this case, it could look like a process that begins with your return to work. Somebody who's had COVID-19 returns to work and they have a safety sensitive job, but we believe that there should be a particular process in place to evaluate whether or not this person, this individual, this employee is cognitively impaired as a result of their COVID-19 infection. Right. And so doing a consultation, and we can do that remotely via telemedicine, telehealth, is what we recommend. Right. And again, this is not across the board. This is not every worker. This is for workers who have safety sensitive duties and may put others at risk as a result of their cognitive impairment. And once we do that initial evaluation, then great, we can clear majority of those individuals to return to work appropriately for their safety sensitive duties. However, in some cases, we may find that the individual needs further tests to identify and qualify their cognitive abilities, right? And that is going to be done through something like neuropsychology evaluation. If you're not familiar with that, It's simplistically a battery of tests that can identify cognitive impairment in detail enough to make a determination, your clinician that partners with you with this, to make a determination of whether or not that person poses a risk, increased risk for the workplace with their safety sensitive duties, right? And so again, we give this to you as a framework to have in place as a result of COVID infection for those, these few, hopefully few individuals who have safety sensitive duties. Depending on what industry you're in, it may have a higher number of individuals that undergo this process. But when we talk about, again, the overarching trend that may happen in the US here, Texas leading the way with the governor announcing, again, 100% capacity, lifting the mask, we want to give you recommendations around what to do in these states. Should you follow suit in terms of getting your workforce back to 100%? What say you work care, right? And Dr. Harris in particular. And so we want to keep it simple here for you. The things we recommend you must continue is mask wearing, right? So if you're in Texas, you have locations there, wear the mask. Even though it's lifted, we still recommend wearing the N95 equivalent for those workers that can't social distance. And or double masking. We still recommend the hand hygiene. So it's going to continue to be effective, particularly as we talk about the variant, Texas being one of the states where the variant is increasing in number, and then social distancing. These simple, straightforward means of protection still will work and still are recommended, even if the state at this point in time is going in the direction of less conservative, right? And as we talk about then a global perspective of what level should you keep precautions in place, yes, it shouldn't be necessarily a one size fits all for every geographic in which you have operations. So having a risk-based approach globally is going to make sense for many of our employers, right? And so the less conservative approach is just continuing with daily symptomatic screening, wearing masks, doing the social distancing, and hand hygiene. And we'll talk about a scenario in which that makes perfect sense from a clinical and risk mitigation standpoint. When we talk about then that moderate approach, it's doing the contact tracing, that says contract, should say it's contact tracing, doing the voluntary testing that many of you are currently offering to your workforce, and then the vaccination verification tracking. That's something that is we have currently at WorkCare. We can help verify those individuals as they're getting vaccinated so that you have a resource, a repository across the board, no matter what state they're in, of who has been and likely to be immune competent against COVID-19. And then finally, the level of conservatism that fits for not just some of our employers, but geographically for the incidents that they're in, is the conservative approach of doing mandatory surveillance testing on a weekly basis. And we know there's a growing number of employers that are going in that direction with the pool testing as well as saliva and other solutions. So with these three approaches, matching that then to your incidents is what we want to talk about. So let's say you have operations in Australia. We know some of our employers do, and we know the incidence in Australia is incredibly low, right? If we look at active cases in the last 24 hours, there's not been any locally acquired cases in Australia, 0, right? If we look at those that they've imported, 10. Right. So if you're in Australia, the likelihood of transmission is low. Active cases, 74 total. They've only had 28,000, roughly 29,000 cases total and 909 deaths in Australia. These are the other geographics that are tracked by the Australian government. But again, if you have the data, such as in Australia, that has shown a decrease in incidents over time since October of last year, right? You can make a recommendation for operations in Australia of taking the less conservative route, right? And that makes sense for that geographic based upon the incidence and the data, right? Whereas if you're in another geographic high incidence, we want to make sure we have the appropriate level of protection for your workforce. And we won't review each of those. We might be doing that in the future here as we talk about, remember this picture, variants starting 2 weeks ago, where they were last week, and where they are this week, growing. And this is just over a 2.5, 3 week time period. And we'll continue to watch these as the California variant became the dominant form of infection in a matter of months. And so as we move forward, we'll track and see how that impacts our goals of herd immunity with these variants. So with that being said, we'll leave you with this graphic. We'll open it up to questions. Thank you so much.
Thanks, Dr. Harris. We'll jump right into the questions as we're running a little short on time. Regarding brain fog, are you familiar with any treatments for that condition?
So brain fog, as we understand it, is for the most part self-limited, meaning that it resolves on its own. Most people do just fine and don't have any permanency to their cognitive impairment. As it stands right now, I have not seen, and I'm not aware of any treatment for brain fog because it is self-limited. There's likely not to be any particular treatment beyond those treatments that decrease the inflammatory response systemically in the body, right? Researchers have looked at the cerebral spinal fluid of those who have had cognitive impairment, and they're not seeing the virus itself in the cerebral spinal fluid, meaning that there's no antiviral approach to getting the virus out of the brain, if you would. But again, those systemic approaches to decrease the effects from inflammatory cascades should be effective to an extent at limiting the impact from COVID-19 on the brain itself as a result of those inflammatory cells populating as we depicted here.
Okay, and another question related to the brain. Are you aware of seizures occurring after recovery from COVID?
There is documentation of seizures after COVID. Similarly, documentation of strokes after COVID, again, usually associated with the microvascular dysfunction as a result of COVID-19. So we are aware of those instances. It's not very common, but there is documentation of the correlation, but not necessarily causal of the two.
Okay, this is a pretty specific clinical question regarding vaccination. Is it safe for someone with a reactive airway who can't have allergy shots and has to carry an EpiPen to be vaccinated?
At this time, the addition to that I would add is if you have some previous history of reaction to vaccines, in that scenario, absolutely hold off getting your vaccine until you consult with your primary care doctor to determine whether or not it's right for that particular scenario.
Okay, and the question regarding the Pfizer vaccine. There have been reports that the Pfizer vaccine may be reduced to one dose because it is only 4 or 5% more efficacious after the second dose. Have you heard about these reports, and is that a reasonable response?
I have not seen any official declarative around moving to a single dose. I know Tony Fauci has said that a little bit ago that there's no imminent move to do that right now. But yes, depending on which variant you're talking about that has been studied against the Pfizer and the Moderna vaccine, there is only a moderate improvement from that second dose. But if we look at the native or wild type COVID-19 or SARS-CoV-2 effectiveness, we're going from 80% after the first dose up to 90 to 95% after the second dose. So I think it is at this point in time still prudent to get 2 doses as is still recommended by both FDA and CDC.
Okay, and regarding the mobility graph that you showed, the mobility graph laid over cases showed the mobility remaining generally consistent over time, but the cases fluctuating greatly. Perhaps I'm missing something. How does that correlate cases to the mobility of the population?
Sure. If we look at the mobility chart here, it's not completely flat over time, right? The overall trend was not dramatic movement between between mobility, right? So we see increases in mobility. The nidus here, the trough that we see in mobility was for the most part across the nation during the time of shelter in place, right? So after shelter in place was removed, we see in which the cases started to increase and then dramatically increase as the mobility. So because this graph is not very tight, you see the dynamic movement in this mobility chart here. It's hard to see a true dramatic trend, right? But we can still see, relatively speaking, the association of the trend when you have a widening of the chart and then narrowing of the chart with the extreme spikes that we saw over the fall and over the winter. Now, is there absolute data showing the correlation here, right, or causal association? No, right? We haven't distilled the data down to cause and effect to that level. But again, the correlation is there. And we know even CDC has published this data so that we can look at it and use it to understand, are we going to see spikes in the future as a result of increased mobility?
And we have time for one last question, and then I just want to remind everyone we do answer all the questions and post them on our website. So be sure to check back there in a couple days. This is regarding a discrepancy between the Washington State Department of Health recommendation for quarantine versus the CDC quarantine. Apparently, according to the questioner, the Washington Department of Health is handing out information that fully vaccinated individuals need to quarantine if they are exposed. But those of you who are familiar with the CDC recommendations know there's some other exceptions to that. If you're fully vaccinated, et cetera, you don't have, if you've not had any exposure and you have been well within the last 3 months, you don't have to quarantine. So what do you recommend this person do? Follow the state guidelines or the CDC guidelines?
Sure, I would follow your local guidelines as you know they have the jurisdiction to make those recommendations to the populace there. So when you're in that jurisdiction, follow those guidelines is the recommendation that we would have to give. And in other jurisdictions, following the CDC guideline would be appropriate. From a impact standpoint, our clinical opinion would be that those who have received both vaccination doses of the Pfizer and Moderna would not need to quarantine for the 90 days thereafter, similar to what the CDC recommends.
Okay, we're out of time. Thanks again, everyone, for joining us. Thank you, Dr. Harris. We'll see you again next week, week 52. Everybody stay safe. Thanks again. Bye-bye.
Excellent. Thanks, everyone. Stay safe and God bless.